diseases of the external ear. Next slide. So you have studied this in your anatomy class, and of course, your second year during your second year precept. We have told you the anatomy of your ear. So it is subdivided into external, middle, and of course your inner ear. Okay, you can just go back to it. Okay, next slide. Again, the anatomical division, it is subdivided into external ear, middle ear, and of course your inner ear. So we will be talking about the external ear. Next slide. So it is said that the function of the external ear is for conduction of sound. It is noted that there is a more or less 5 decibel gain with the pinna, and it is protective of the middle and the internal ear. So the demarcation between your external ear and your middle ear is your tympanic membrane. It is also it gives a static aspect of facial appearance. Okay, next slide. The shape is defined by the elastic cartilaginous plate. So once you have the necrosis of your cartilage, your pinna will look differently from most. Okay, next slide. So this is the auricle. Next slide. So there are we'll go to different congenital anomalies or different, not really congenital anomalies, or different subsets or different types of ear or the pinna. You can have, some patients can have butt or loop ears. Next slide. Or pwede rin yung parang tinatawag nilang the pinna is too thin or parang F-like ears. Next slide. You can have macrotia. So for Chinese people, they believe that having a big ear equivalent to long life. Of course, hindi naman talaga to medically, or there's no scientific basis for that. Next slide. And of course, a more common problem is the microtia. So depending on the grade, you have grade 1, grade 2, grade 3, and grade 4 microtia. So as you can see, the difference between grade 2 and grade 3 is that with grade 3, there is no ear canal already. However, with grade 1 and grade 2, you still have the ear canal. So sometimes it's better, the patient have a better hearing than the grade 2 and the grade 3 and the grade 4. Next slide. So chondroma can be seen at the pinna. So this is not a soft tissue. It is usually hard and solid mass in the auricle. There's nothing other than the aesthetic part of the chondroma. Actually, it doesn't affect the hearing of the patient. So sometimes para siyang ano lang din yan parang mga keloid. So if you're going to feel the chondroma, it's quite solid and hard. So some patients will have it taken out. So that's the only thing you can do. You have to excise that surgically. Next slide. Now this is I know a lot of you have this also, the preauricular sinus or fistula. This is a congenital problem of the first bronchial cleft anomaly. So depending on the sinus, if it's infected, that's the only time we give antibiotics. Sometimes there's some patients with this preauricular sinus na hindi naman na-infect and it doesn't bother them. We don't do anything. However, if it gets infected so often, aside from giving infection, we suggest to excise the sinus. Okay, next slide. Okay, so this slide will show you how to examine before you do otoscopy. Like we have told you in your second year precept, always check for the pinna, the auricle externally before doing otoscopy. So ano lang yan, you have to have a good illumination, look for any masses, any abscess formation, hyperemia, or even some abrasion, or even some congenital anomalies externally of the pinna. Next slide. Okay, this is one way uh, uh, ano ba to? You have to do this maneuver for you to be able to look at the external canal prior to inserting your otoscope. So it's one way of retracting the tragus. Okay, next slide. Now, when you do your otoscopy, it can be done however you want to hold the otoscope. It can be an inverted fashion or just the classical way of holding the otoscope. Just as long as you will be able to see the external canal and, of course, the tympanic membrane. Okay, next slide. Again, just some anatomy of the ear, the external ear, middle ear, and of course the inner ear. Next slide. So most patients will come to our clinic because of ear pain. So when you have a patient with ear pain, you need to look for a lot of things. Of course, look for swelling in the post-auricular area, look for abscess. You touch the tragus if there is a tender, and of course the external canal. Look for any narrowing, inflammation, or even foreign body in the external ear canal. Okay, next slide. So, what conditions usually present with ear pain? For the auricle, usually a patient with traumatic hematoma, perichondritis, when patients have a trauma over that area, like for example, a vehicular accident, there can be laceration over the area. Look for any cyst or mass in the auricle. And for the canal, specifically the external canal, otitis externa is very common, secondary to like initially manipulation, then infection. It can be a bacterial infection or even a fungal infection. And look for any foreign body or even like an obstructive obstruction from impacted cerumen. This can cause pain also. With tympanic membrane, some patients will have ear pain because of meningitis. So look at the status of your eardrum. And of course, some patients who have pharyngitis or ATP, they can have referred pain, and sometimes they come to your clinic uh, no having that ear pain, and it's only a referred pain from a pharyngitis or ATP. So you need to check also the oral cavity and the oropharynx if patients come to you with ear pain. And of course, post-auricular swelling, secondary to abscess or subperiosteal inflammation. Next slide. So first, perichondritis. This is an injury to the auricle and may involve the cartilage. Once it is infected, it is the more common bacterial agent is the staph and the Pseudomonas. So TM usually appears normal and there is no hearing loss unless there is already otitis externa or involvement of the external canal. So you need to give antibiotics for this patient. Otherwise, if the perichondritis will not be controlled, there can be necrosis of your cartilage and it will lead to a problem later on, like a cauliflower ear. So next slide. So perichondritis can also result from like ear piercing. So some ear piercing, pwede mag-infect muna initially, then there can be hematoma or even serous formation. Again, once it is not controlled, the problem here is that the cartilage can be necrotic initially, then it ensues like a cauliflower ear, and if it's a infection, you need to give antibiotics. Of course, if there's hematoma or even like a seroma, you need to evacuate that. Next slide. So this is what I'm telling you. Mostly seen in patients with trauma in the ear, secondary to, like, for example, a vehicular accident or even a fist fight. For boxers, if you've noticed, Manny Pacquiao and a lot of boxers, they have cauliflower ear because of the persistent hematoma prior to the after their fights. Kahit yung mga MMA fighters, the problem with that is that because of the trauma, there is accumulation of blood or even seroma over that area, which you need to evacuate. Otherwise, that it can get infected again because of the decreased vascularity of the cartilage of the pinna. It can result into necrosis of your cartilage, and of course, again, it leads to your cauliflower ear or deformity of your pinna. So with when you have patients like this, what you need to do is you need to evacuate the corresponding problem. Like if it's blood or even seroma or abscess, you need antibiotics aside from evacuating or incision and drainage. Next. The only problem with this with evacuation is that if you don't put pressure over the pinna after evacuating the hematoma or the serous seroma, it can accumulate in a few minutes. So you need to put bolster. So I have a patient, ayaw niya kasi nang nilalagay niyang tinatahi pa. So alam niyo yung clothes, yung peg for ano ba tawag mo to? Or even yung fastener, yung may clip, you can use that because if you don't put pressure over the pinna after evacuation, it will just accumulate and it it becomes recurrent. So you need to put pressure on it for a few days, like 1, 2, or 3 days, and just to prevent reaccumulation of the hematoma or seroma. Next slide. So this is the resulting problem if you don't if there's necrosis of your cartilage, if you don't evacuate the hematoma or the seroma or even the abscess. Next slide. Now, a sebaceous cyst can be seen at the external at the pinna, also at the external of the auricle. So just be careful. Sometimes before we excise sebaceous cyst, you should be very sure that it's just a sebaceous cyst. So sometimes we do an imaging just to make sure that it has no connection internally. May ibang kasi na ganyan, hindi lang pala sebaceous cyst. It can be hemangioma, sometimes a more pressing problem like it can be part of like a tumor that is it is just a connection from the inside going outside. So before you excise an apparent sebaceous cyst, make sure that it is really a sebaceous cyst. So sometimes imaging can be done before you excise these things. Next slide. And this is what we see a lot of these keloid formation after piercing. So I don't know what is the reason why it has increased the incidence of the keloid. Kung is it secondary to the material being used or even how sterile the piercing done to our patients. Kasi we see this a lot compared before. Nowadays we see a lot of keloid former and keloid formation for patients with piercing. So just be careful. And with keloid, you need to excise this because it's unsightly. It doesn't look good, and the problem with keloid too is that the recurrence of keloid is very common. So even after you remove the keloid from the auricle, you need to put some injection, or steroid injection, to prevent it from recurring. And not to mention the deformity that it can cause after excising the keloid. So next slide. Now we go to otitis externa. So this is a very common disease entity for ear problems from our patients. So next slide. This is a view of your external canal with a severe otitis externa. As you can see, the canal is almost stenotic and there are some debris. So it's very difficult to treat this kind of patients. So you need to remove the debris, and you cannot just instill some otic antibiotics because it will not go inside. So sometimes you need to put some earwick as a conduit for the medication. And of course, aside from that, you can give oral antibiotics if it's not possible. So next slide. So these are the basic principles in the treatment of otitis externa. So yes, I agree. Avoid too much manipulation, and you have to keep the ear dry all the time. You can give Comoxiclub, your clindamycin. Again, the otic drops will depend on how severe or how stenotic the ear canal. Of course, if it's too severe or the stenosis is quite severe, then otic drops is not good to give as it will not go inside. So you also give NSAIDs for these patients from celecoxibs, ibuprofen, or even the higher type of NSAIDs like yung mga ano mo what's this uh, heterocoxibs. Next slide. So actually this slide will just tell you you need to remember that your ear canal on average is 2.54 centimeters. So when you're cleaning your ear, remember that that size should not be more than that, because otherwise you will hit the eardrum, and there's a possibility that you may perforate the tympanic membrane if you do more than that. So sometimes you need to guard your cleaning material or your ear tips when doing that. You just have to estimate, mukha bang 2.54 centimeter na ba to? Then you just have to lessen that before you clean. And actually, cleaning should only be done at the external one third of the ear, because
Recording in progress.
when we see earwax at the inner one third, you know that that earwax has been pushed already by cleaning your ear. So kailangan ano lang siya. Okay, next slide. So this is what I have mentioned earlier, the earwig. So usually we put an earwig if there is a stenotic ear canal secondary to severe otitis externa. So it's a conduit for the medication to be that you need to instill, so it will go inside that canal. Otherwise, kung wala kang earwig, you cannot put an otic drops for this type of patients. Next slide. Now we have a necrotizing otitis externa, or what we call a malignant otitis externa. So even this is called a malignant otitis externa, this is not cancerous at all, okay? This is secondary to a Pseudomonas infection, sometimes a methicillin-resistant Staph aureus, usually seen in patients with immunocompromised states like elderly, with diabetes, with cancer, or even like uncontrolled like HIV, something like that. So again, this is infectious in nature, so this is not cancer at all. Okay, next slide. So necrotizing otitis externa, it is an infection of the external auditory canal, and it can involve the temporal bone. So osteomyelitis is a result of the infection, and it's very difficult to treat once the patient has osteomyelitis. So usually the causative organism, like I've said earlier, is Pseudomonas, and it is also possible to have a methicillin-resistant Staph aureus. So commonly seen in elderly, diabetic, or immunocompromised patients. Next slide. So usually the patient will present with persistent and severe pain, false smelling otorrhea, there is granulation when you examine the ear, and of course, because of the granulation, there is a degree of conductive hearing loss. Next slide. So in severe cases, they can present also with facial nerve paralysis. Next slide. So management is geared towards Pseudomonas or methicillin-resistant Staph aureus. So you can give your aminoglycoside, your fluoroquinolone, or your semi-synthetic penicillin combination. Of course, if the ear canal is patent, once you have removed the granulation or any debris there, you can also add topical antibiotics or otic drops, like a combination of your ciprofloxacin and of your dexamethasone. Once it has necrotic tissues, you need to do surgical debridement. And of course, if it's the patient is immunocompromised, you may need to refer the patient to infectious and endocrinology consultants. Next slide. Otomycosis is also a very common disease entity of the external canal. So it is seen 10% of otitis externa cases. The most common pathogen is Aspergillus. Sometimes Candida also. This is secondary to prolonged treatment of bacterial otitis externa. So the situation is a patient came to you because of otitis externa, a bacterial otitis externa. So you gave the patient otic drops, antibiotics, and nawala na yung patient, did not follow up, and the patient used the otic drops for very prolonged period of time that it resulted to an otomycosis. So that's a very common situation or scenario. Of course, some patients naman, they don't have that history. Some patients, because of their immunocompromised state, there is a frequent manipulation. So sometimes, aside from bacterial otitis externa, they develop also otomycosis. So this is very common in our clinics. Next slide. So with otomycosis, you need to clean. Oral Tolay is very important in treating otomycosis aside from giving the proper medication. So you can use acetic acid as a medication and antifungal otic drops. Okay? So keep the ear dry at all times if possible. So with otomycosis, aside from oral Tolay, you give the medications geared toward fungal infection. Next slide. So another problem patient that will present to you is itchiness. There are a lot of causes for itchiness. It can be eczema, seborrheic dermatitis, a cerumen that is adherent to your ear, a wet canal, sometimes may konting pumasok lang na water sa ear, then sometimes inisip na nila na it is infectious in nature. So itchiness is also cleaning. They have daily cleaning of your ears is a habit forming problem that can cause the itchiness of your ear. Of course, if you clean your ear daily, you remove or the natural oiliness or the wax that's supposed to prevent that from happening. So if the ear canal is too dry, it can result to itchiness. Next slide. So when the patient come to you with very itchy ear, you need to determine the cause of itchiness. Sometimes, aside from what I've told you earlier, some patients, because of allergy, like pwedeng allergic rhinitis, it can also present as itchiness of the ear. So once you have determined the cause of the itchiness, if it's bacterial, if it's fungal, you give medication for that. If it's just dryness, you can emollients or even ask the patient to use oil to just make sure that the ear canal is not too dry to cause this itchiness. And of course, if there is some scattered cerumen, you need to remove that uh, to lessen the itchiness. So I usually give steered combination also, more of an ointment if I don't see any infection. So sometimes because of just eczema or just a seborrheic dermatitis, I can give some steroids that can be placed in the external canal, so to prevent or to lessen the itchiness. Okay, next slide. Now, osteoma. Now, we need to discuss osteoma comparing to exostosis. So, just remember this. Exostosis is usually multiple. So, exostosis is multiple, usually bilateral. It is associated in swimming in cold waters, as compared to osteomas. Osteomas usually it occurs in singly, and it's not bilateral, and it's not associated with cold exposure to cold water. So just bear that in mind that osteomas are multi, bilateral, and in uh, associated with cold water swimming. Okay, next slide. Okay, so this is a very good picture. So exostosis, usually multiple. Osteoma, usually it occurs singly. And with exostosis, it occurs bilateral with both ears and associated with cold water exposure. Okay, next slide. So the management is surgical excision because it impedes natural outward migration of earwax, thus causing impaction and hearing loss. So you need to remove that. Next slide. So when a patient comes to you because of decreased hearing, there are a lot of things that you need to entertain. Possibly, is there foreign body? Is there stoma or exostosis? An impacted cerumen? Probably an impacted tympanic membrane perforation. Of course, sensory neural deafness, conductive deafness, and of course, trauma. So you need to consider all of these. Next. So with that, with cerumen, a very common problem impacted cerumen from childhood to even to adult patients. So cerumen is hydrophobic, so it provides barrier to penetration of water. So it also traps dust, dirt, and pollens, and a little bit acidic at 6.5 to suppress growth of bacteria and of course fungal infection. So it is produced by ceruminous and sebaceous glands. So it has some benefit in having some earwax. Wag lang masyadong impacted na sobrang dami that it causes hearing loss. So it's okay to have minimal earwax because again, these are the benefits of having the cerumen in your ear. Next slide. So there are two different types, wet and dry. Asians in general have dry wax compared to Caucasians. They have usually wet cerumen. Next slide. So there is a normal migration of earwax. Once it is produced in the external canal, there is a normal migration of your earwax. So you don't really have to clean it daily, your ear. And if you're going to do it, use the smallest Q-tip that you can avail of. And it has to be just the external part of your canal. Next slide. Next slide. This is just an impacted cerumen. So when do you remove the cerumen? You don't routinely need to clean your ear. So, if a patient asks me, Doc, gaano ba kadalas maglinis ng tenga? Usually, once a week should be enough. And of course, the only time we remove wax is if it's excessively produced by a patient. Kasi may mga patient talaga na sobrang mag-produce ng wax. And of course, if it's causing hearing loss already and infection, then you need to remove that. Next slide. Okay, next slide. So Sam, when we remove earwax, either we use suction or you can also do some ear irrigation. The problem with ear irrigation is that it is not recommended to do irrigation if the patient have a tympanic membrane perforation. And of course, it's quite messy. You'll need to use water. Aside from that, sometimes the patient will experience dizziness with the ear irrigation. Next slide. So in my clinic, I usually do suctioning rather than ear irrigation. But of course, once in a while, there are some cases that you need to do ear irrigation rather than ear suctioning. So there are some chemical that is used to soften the earwax. So actually, no chemical will dissolve the earwax. So some like hydrogen peroxide or even docusate, they will only uh, soften the ear, so it will be easier to remove the wax. So actually, there's no chemical to dissolve the earwax. So we discourage the use of big cotton buds, the frequent cleaning of the ears, and of course candling. I've seen a lot of patients who had candling and have resulting to ear infection. So we don't recommend that. Next slide. Some of the instruments that we use in our clinic for ear cleaning. Okay, next slide. Now, foreign body. If you notice, there's a cockroach in the external canal. So, aside from cockroach, pwedeng mga fly, pwede ring mga ano, pero the most common that we have seen animate foreign body is cockroach. Next slide. So, foreign body can be animate or inanimate. For inanimate, for kids, usually beads, nakikita namin, clay, even paper, even cotton. So, paper. So, nakikita natin yan. Of course, if it's animate, you need to immobilize that insect first. So usually we drown it with oil. You can put anesthetics before removing. It's quite hard to remove a foreign body, an animate foreign body, if it's still alive. Saka kasi once you do your suctioning, it will just go deeper. So it's best when you remove the foreign body, like a cockroach, kailangan na immobilize na or dead na before you remove it. So next slide. Okay, so if it's cockroach, kill the insect by instilling lidocaine or alcohol. Me, I use mineral oil because of the viscosity of the oil. Actually, it lessen the movement of the cockroach or the insect. Unlike with water lang or even lidocaine. Actually, lidocaine is oil based. So if you put just water to drown the foreign but the cockroach, sometimes masyado siya lang magalaw and it can bite the surrounding structures, like they can go penetrate the eardrum. So it's better to use a highly viscous fluid like oil when drowning the foreign body, the cockroach for that matter, before you remove that. Of course, for children, it's better to do the foreign body removal under sedation. Because usually hindi naman sila cooperative eh. So once they hear the noise of the suction or even any instrument, they see the instrument, medyo nagpapanik na mga yan. So it's better to do foreign body extraction for children under sedation. So do not attempt to remove foreign body if you do not have the right instrument. Of course, that is very important. And of course, the skill. Next slide. Now we go to herpes zoster oticus. This is herpes zoster oticus is just reactivation of a varicella infection. So once you have vesicles over the ear from secondary to varicella infection, so this is a herpes zoster oticus. However, if there is facial nerve paralysis already, so the triad for Ramsay-Hunt syndrome is there is a vesicular lesions, ear pain, and facial nerve paralysis, then this is already a Ramsay-Hunt syndrome. So it affects people who have had chickenpox before, and of course, the treatment is antiviral medications. So next slide. Now, another condition for the external ear is squamous cell carcinoma. So you need to be very careful about these things. So a biopsy is needed to be able to diagnose squamous cell carcinoma. Once it is diagnosed, the treatment is surgery and of course additional radiochemo depending on the condition of the patient. Next slide. A basal cell carcinoma is also quite common in patients like mga farmers or even to patients exposed to sun, uh, like mga pasyente natin na they love, like if the patient is a Caucasian and loves going to the beach, be careful about these things. Sometimes you see that. I've worked in Australia as a skin cancer doctor and I see a lot of basal cell carcinoma, squamous cell carcinoma, or even melanoma. So sometimes basal cell carcinoma is quite common to this kind of patients. So depending on the exposure, how long the exposure to the sun is, how intense the sun when they are exposed, and of course the type of skin they have. These are very common to patients with those exposure, and like what Level said, they don't produce melanoma, what's this melanin so much that it their exposure to sun to them causes this type of diseases. Of course, the treatment for basal cell carcinoma is excision. However, with basal cell carcinoma, sometimes if it's not a nodular type, it's only a superficial. There are creams that can be used to treat basal cell carcinoma. You can do cryotherapy if it's just a superficial type of basal cell carcinoma. You can also use Aldara or Imiquimod cream to treat the basal cell. But if it's a nodular type of basal cell carcinoma, the treatment option is excision of the basal cell carcinoma with good margins to prevent recurrence. Next slide. So the references, probes, and Ballinger's otolaryngology head and neck. So if you have any questions, you can chat, or you can type it in the chat box, or you can open your mic and just ask the question. So if there is none, wala na questions. Thank you for listening. And if you have question later on after this, at bigla na lang sumulpot yung question nyo, you can ask any residents and they can answer that. Thank you.